Go.
So today we're going to be doing an EJV. There are numerous reasons why we do an EJV, such as if we couldn't get IV access peripherally, we couldn't get IO access, or we simply wanted IV access with a high flow rate and a large bore needle. So first things first, we're going to ask for our patient's consent. Do I have my patient's consent?
Yeah.
Cool. If our patient was in cardiac arrest, they obviously couldn't give consent, and thus consent would be implied. So the first things first, before we do anything with our needles, we're going to distend the jugular vein. The way we're going to do this is we're going to place our patient's head on a 45-degree angle and tamponade subclavicularly in order to backlog some blood into the jugular vein. If this doesn't distend the jugular vein, if our patient was conscious, we could ask them to bear down, we could put pressure on the liver, or we could raise their legs. Now that the jugular vein has been distended and that we can see it and we can palpate it, we're going to be preparing our cannulation kit, which includes alcohol swab, our cannula with a syringe attached to it with 3 mils worth of saline that's been drug checked. The reason for this 3 mils of saline is to prevent the risk of an air embolus due to the high flow rate of the jugular vein. We have our lure plug to stop the patient from bleeding. We have our PosiFlush to check that the line is patent, that has been drug checked by my offsider. Gauze to stop bleeding, Tegaderm to secure the line, and Sharps container for Sharps etiquette. So first things first, in all cannulations we will be sterilising the site. And we will do this in a circular motion in order to not push dirt back into the sterile environment that we've just created. With our cannula, it's a bit different. It's quite long, and so we'll be wanting to make sure that we have a steady hand, but also we're wanting to be able to draw back the syringe to check for flashback with our pinky finger, while also inserting it like a normal cannula. Sharps out. So we're going to be tamponading subclavicularly and putting as much traction that we can onto the vein in order to stop it from rolling. We're going to be inserting on a 15 to 20 degree angle. We're going to be drawing back to check for flashback. I've got flashback. We're then going to be lowering and inserting the needle, and then we're going to be placing the cannulation into the vein while extending the needle and tamponading. Sharps are out, sharps are away, and we're going to be placing our lure plug on. With our lure plug now on, we can now secure safely the cannulation and not have the patient bleed. We're going to check that the line is patent. Now, the reason why we have cannulated on the upper half of the jugular vein is there is a risk that if you tamponade on the second half, that the needle can puncture the pleural cavity and cause a pneumothorax. And due to the length and size of the syringe and the cannula, there is a risk that with an unsteady hand you can shave off some plastic and produce a plastic emboli. Now the mannequin is faulty and that was the cause of the squirt, but I don't feel any resistance with my flush, and I'm quite happy that I had flashback inside the flush as well. So I'm quite happy that the line is patent and secured. We will be further securing the cannulation with our Tegaderm, and we will be wanting to make sure that we can still see the line so that we can verify that we do indeed have flashback. Now, because I don't have any nails, I'm doing very bad practice to remove the plastic, but obviously on the road and in real life I wouldn't be doing such things. We'll then be securing our lure plug down, and we'll be also noting the time, date, and gauge number of our cannulation for hospital use, but also for our documentation. So now that the line is clear, we can then administer drugs into the jugular vein, and Bob's your uncle.
Nice.